This conference will now be recorded.
Oh. Good morning, everyone. I'm Dr. Sundeep, and I'm going to explain the topic of seizures and epilepsy, which is, I think, one of the important essay questions for you. I think now we are getting into the definition of seizure. Seizure means to take the position of. It is actual definition of seizure is it's a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. The important word here is the transient. I think it is not permanent or it is not long standing. It is a transient, means which lasts for only a few minutes or a few seconds, or which is a temporary thing. And when coming to epilepsy, it is a 2 or more unprovoked seizures. Means unprovoked means we don't know what is the cause, what is the triggering factor, and it refers to the clinical phenomena rather than a single disease entity. Describes a condition in which a person has a risk of recurrent seizures due to chronic or underlying process. As you can now understand the difference between seizure and epilepsy. Epilepsy has a chronic underlying process, and a seizure usually you have a provoked cause, whatever might be the cause. For example, any hypoglycemia, example any hyponatremia, we know the cause and we treat it, and that is a seizure. Epilepsy, here you can see it is a clinical or a recurrent phenomena which is occurring because of some chronic underlying process. And the classification of seizures is, this is very important. You have to know what type of seizure the patient is having, whether it is a focal onset or a generalized onset. When it comes to focal onset, it originates in one particular area of single cerebral hemisphere. In local onset, it can be further divided of having intact or impaired awareness. In focal onset seizures, the patient may have intact awareness. I mean, patient may be aware of the conditions around him, but atonic clonic seizures might happen, or motor or non-motor onset, or evolve from the focal to bilateral tonic-clonic. When it comes to generalized, it is of motor or non-motor. The important subset of seizure here is absence seizure. Absence seizure is a generalized onset seizure. I'll further explain you in a coming slides, but you must know this classification, and you have to write this classification of seizures as focal onset and generalized onset whenever the question is given to you, or whenever even you are in a further years when you're going to treat a patient. Focal seizures originate within the networks limited to one brain region. I mean, previously the term partial seizures are is the term that is used for focal seizures, but now partial seizure is a term that is no longer used. Now we use the term focal seizures, originate with as I can say, and focal seizures are usually associated with structural abnormalities of the brain. Generalized seizures arise within and rapidly engage networks distributed across both cerebral hemispheres. Generalized seizures may result from cellular, biochemical, or structural abnormalities. As I said, focal onset seizures and generalized seizures. I'm going to explain now the focal onset seizures. New classification emphasizes more on the awareness. I mean, whether the patient is aware of is having seizures or aware of the circumstance around him, aware of the surroundings around him, or is he unaware or impaired consciousness, and what is the nature of the onset. Focal seizures can also evolve into a generalized seizure. It may start with the focal seizure, but it can evolve into a generalized seizure as the time progresses, or as the focal seizures keep occurring repeatedly. Then it can evolve into a generalized seizure. In the past, and it was referred to as focal seizure with secondary generalization. This is very important term, you must remember. Sometimes it starts with only like lip smacking, some abnormal behaviors, and then it progresses to the hands and legs. Then you have to call it as a focal seizure with secondary generalization. The routine interictal means in between the two seizures. The time between one episode of seizure and the other episode of seizure, the routine interictal EEG in patients with focal seizures is often normal, or may show brief discharges termed as epileptiform spikes or sharp waves. Usually in focal onset seizures, as it is explained in EEG, it is normal, often normal. Focal seizures with intact awareness. As I said, focal seizures are of two types, one with intact awareness and one with impaired awareness. And focal seizures with intact awareness. Focal seizures can have motor manifestations like tonic, clonic, myoclonic, or non-motor, sensory, autonomic, or emotional symptoms. So I'm going to explain what is the tonic, clonic, myoclonic later. The three additional features of focal motor seizures are Jacksonian march, Todd's paralysis, and epilepsia partialis continua. And focal seizures, these three are important terms that you must remember. Focal seizures may manifest as changes in somatic sensation, paresthesias, vision, that is flashing lights, and equilibrium, that is vertigo, and autonomic function, flushing and sweating. In the previous slide, actually, Jacksonian march means, the focal activity that's going to start seizure happens to be starting in one particular area of the brain, and then it transfers to all the cerebral hemisphere, and gradually the seizures also, starting from one limb, it progresses to other limb and other limb. Usually the seizure progresses from one part of the body to the other part. It starts with the face and then with the neck. Then I think the progression of seizure is usually termed as Jacksonian march. And Todd's paralysis means, after an episode of seizure, the patient transiently can have, for a brief period of time, the patient is going to be paralyzed for some part of the, if for example, if right upper limb is having a tonic-clonic seizure, after the termination of that seizure, the hand doesn't work for some time. Usually it looks like a paralyzed limb, but actually it isn't. It is because of the postictal paralysis. That is actually, the term postictal is very apt for this. That is Todd's paralysis. After an episode of seizure, the patient experiences the paralysis in that particular part. Epilepsia partialis continua is a severe form where the patient can even die. That's not of much importance to you. Some patients describe odd internal feelings such as fear, sense of impending change, detachment, deja vu, micropsia, and macropsia. These are referred to as auras. I mean, the auras means the feelings of the patient before the onset of a seizure. He can have sometimes these sort of feelings such as fear or impending change, or deja vu, something like previous things or already did happen. You might have known that. And focal seizures with impaired awareness. This is the second form of the focal seizures. The patient's ability to maintain normal contact with the environment is transiently impaired. Whenever the word transient, it is only a temporary. These seizures frequently begin with aura. The start of the ictal phase is often motionless state, which marks the onset of a period of impaired awareness, which is accompanied by involuntary automatic behaviors like chewing, lip smacking, and swallowing. The patient have abnormal swallowing. He keeps on swallowing by keep staring at the other persons. Then you must suspect a seizure or lip smacking. He will have an abnormal, lip smacking, the lip movements which no other person will have before or even during the onset of a seizure, or chewing patterns as well. You must recognize them, and if you find any abnormal, these are called automatisms. If you find any abnormal automatisms suddenly in a patient, suddenly in a person while you are with him, then you must suspect seizure, whether he is in contact with the surroundings or not. Then you must proceed. Then you must suspect, and immediately the patient, that particular person must be taken to hospital. Patient is typically confused following the seizure. There is a term called postictal confusion, and with focal seizures with impaired awareness, there is a postictal confusion. Generalized onset seizures. Generalized seizures arise at some point in the brain, but immediately and rapidly engage neuronal neuronal networks in both cerebral hemispheres. The The types of generalized onset seizures are the typical absence seizures. You must remember that the absence seizure is a generalized onset seizure. It is characterized by sudden brief lapses of consciousness without loss of postural control, lasts for only seconds, and there is no postictal confusion in absence seizure, and you must remember that. For example, usually the patient doesn't know that he's having an absence seizure. He just keep look. For example, if a student is having an absence seizure, he just keeps staring at the board. He just got lost for 2 or 3 minutes. He doesn't know what's happening, and suddenly he comes to consciousness, and he's fine. There is no perspective confusion, and even the person can't know what's happening, and the people around also can't recognize these type of seizures, only because the loss of concentration, the loss of what's happening around, it may lead to poor school performance, poor academic performance, and then usually these type of absence seizures are recognized. They may be accompanied by subtle bilateral motor signs such as blinking of eyes and chewing. Usually, as I said, absence seizures occur between the age of 4 to 10 years of age. That is during the early school going age. Main seizure type in 15 to 20% of children with epilepsy can occur hundreds of times per day. As I said already, it can happen frequently. Within a 1 hour, it can happen 4 to 5 times. The patient, that particular student also doesn't know that he's having a seizure. Even the people around him can't recognize unless in that 1 or 2 minutes, if they are going to recognize it. Plus, further in history, the bystander tells that he's daydreaming. He just keeps staring at the board, or he just keeps staring at someone. Decline in school performance recognized by the teacher. EEG findings generalized. When you perform EEG for these students, then generalized symmetric 3-head spike and slow wave discharges that begin and then suddenly superimposed on normal EEG background. And sometimes hyperventilation tends to provoke these EEG changes. These are some EEG things, and it might not be that useful at this point of time. Sometimes the atypical absence seizures. It can be differentiated from typical absence seizure by the lapse of consciousness is usually for longer duration in atypical absence seizure, less abrupt in onset and cessation, more obvious motor signs, and in EEG generalized slow spike. Whenever you get the term motor signs, you must know that these things which happen, the voluntary movements, whatever, the lip smacking, or the violent movements of the hands, or violent movements of the head, or the abnormal behavioral patterns of that particular person. Suddenly he's having an abnormal stare. These are all called the motor signs. In EEG, there is generalized slow spike, slow wave pattern with frequency of less than 2.5 Hz. Usually, atypical absence seizures are less responsive to antiepileptics, usually associated with structural abnormalities of the brain. GTCN means generalized tonic-clonic seizures. Most common seizure type resulting from metabolic derangements. The common metabolic derangements that lead to generalized tonic-clonic seizures are hyponatremia and hypocalcemia, and of course hypoglycemia as well. So whenever you get a patient, whenever you see a patient of generalized tonic-clonic seizures, you must check the sodium levels, calcium levels, and the blood sugar levels. Usually these are the things that cause the generalized tonic-clonic seizures. You have to correct them. Without correcting them, even though you give many antiepileptics, these seizures are not going to terminate. Initial phase of the seizure is usually the tonic contractions of the muscles throughout the body, characterized by ictal cry, impaired respiration, cyanosis, pooling of secretions in oropharynx, contractions of jaw muscles resulting in tongue bite. Marked enhancement of sympathetic tone leads to increased heart rate, blood pressure, and pupillary signs. After 10 to 20 seconds, it evolves into clonic phase, muscle relaxation. What is tonic-clonic? Tonic means there is a vigorous muscular contraction, and clonic means muscular relaxation. There is vice versa of these things happening continuously. There is a strong tonic contraction, and then suddenly it releases. So that is called the tonic-clonic seizures. Generalized because it happens to be the neuronal networks that is happening all both the cerebral hemispheres. Postictal phase, unresponsiveness, muscle flacidity, What do you mean by postictal phase? In postictal phase, you see the unresponsiveness of the patient. Sometimes when you see the patient is unresponsive, and you tend to mistake it for the syncope. You don't know that previously the seizure had happened. So sometimes you can mistake the seizure for a syncope. Muscular flaccidity, excessive salivation, partial airway obstruction, bowel and bladder incontinence. There is typically a period of postictal confusion in EEG tonic phase. Progressive increase in generalized low voltage fast activity followed by generalized amplitude. I think EEG findings, there are only 2 to 3 findings that I will tell to you. I will say what are the important EEG findings in a particular thing. You don't have to remember all the EEG findings for every type of a seizure, but I will tell what are the important things to remember to write in exam, or the basic EEG findings, and later I will tell. Atonic seizures. Atonic seizures is characterized by a sudden loss of postural muscle tone lasting 1 to 2 seconds. The consciousness is going to be briefly impaired. There is no postictal confusion. A very brief seizure may cause a quick head drop or nodding, a large seizure, which causes the patient to collapse, leading to head injury. As I said, the EEG findings, there is no need to remember for every type of seizure. It is very important, one of the important subset of seizures, myoclonic seizures. It can be asked as a short note for you. Myoclonus is a sudden and a brief muscle contraction that may involve one part of the body or the entire body. When you look at a patient, suddenly he's talking to you, he's doing his daily routine activity. Suddenly there is this sudden movement of hand or sudden movement of leg, some sudden abnormal movement, sudden twisting movements happen, and suddenly the patient goes into a stare. That is called myoclonus, and suddenly it stops, and again he starts talking normally. So this finding, this myoclonic jerks, usually is happen in the young patients, that is in adolescent age group, and this, and so it is very important subset, and we have to treat it because it happens in younger age group patients. They must be treated accordingly so that they have a better better life afterwards. It's most commonly seen associated with the metabolic disorders, degenerative CNS diseases, and anoxic brain injury. And you must have known that during the seizure activity is going on, the oxygen supply to the brain gets disrupted. So you have to terminate seizure as soon as possible to prevent the brain injury. As you know, without oxygen, the brain doesn't work. If the blood supply to the brain is cessated for 8 to 10 seconds, there is going to be a ischemic injury to the brain, and the brain stops working, and it may lead to seizure. So it is very important that you must terminate the seizure and prevent the anoxic brain injury. Here, in firm myoclonic seizures, EEG is very important. You must remember this. The bilateral synchronic spike and slow wave discharges. You have to remember these terms, the bilateral synchronous spike and slow wave discharges for myoclonic seizures. They are predominantly a feature of juvenile myoclonic epilepsy. As I said, it is more common in juvenile age group, so it is very important to identify the myoclonic seizures in those patients and treat accordingly. Treatment I will tell you later. And epileptic spasms, characterized by briefly sudden flexion or extension of predominantly proximal muscles, including the frontal muscles. EEG is not that important for epileptic spasms, and it's just for a theory sake. Usually it's not that important for you. So some epileptic syndromes, as I said earlier, JME means juvenile myoclonic epilepsy. It is a generalized seizure disorder, appears in early adolescence and characterized by bilateral myoclonic jerks. As I said, the myoclonic jerks, how can it happen? The abnormal movement suddenly happening, and the patient just goes into a state. You get the movements that are usually not seen, sudden vigorous movements. The patient usually, it's not like a generalized tonic-clonic seizure where there will be frothing, there will be cyanosis, and there will be the patient, suddenly loses his consciousness on the ground. It's not that type of a seizure. The patient, when he is sitting, when he is speaking to you, or when he's having any conversation, the patient suddenly have the start to have these type of abnormal movements, and the patient goes into a stare. Usually there is no loss of posture there. These drugs are more frequent morning after awakening. 1/3 of patients may experience absent seizures, and usually this juvenile myoclonic epilepsy responds well to anticonvulsants. Usually for these patients, in juvenile myoclonic epilepsy patients, there is a family history of epilepsy. Usually one of the family members will have the epilepsy, and it is provoked by sleep deprivation. Usually it is one of the most common type of seizure which is provoked by sleep deprivation. It is very important to diagnosis. There is also genetic association. So whenever you get these patients, okay, treatment part I will go later on. I'll tell later on. It is a very important short note question for you, which is Lennox-Gastaut syndrome. Occurs in children with the following trait. Multiple, there is multiple seizure types in Lennox-Gastaut syndrome: tonic-clonic, atonic, or atypical absence seizures. One of these seizure types will be present in the patient. And the EEG finding is important in this. You have to remember this. EEG shows less than 3/8 spike N wave discharges, and there is impaired cognitive function. There is the patient suddenly doesn't recognize the people, or suddenly doesn't recognize his surroundings. These type of things normally happen, and Lennox-Gastaut syndrome is associated with the CNS disease, mutations, or developmental abnormalities, perinatal hypoxia, and trauma. Developmental abnormalities in early age of development, where during the vaccination age, and those are. And it's due to its multifocal nature, patients have poor prognosis in consequence of poorly controlled epilepsy. For theory's sake, it's a very important question for a short note, and you must know what is Lennox-Gastaut syndrome. And one of the subset of epileptic syndromes is mesial temporal lobe epileptic syndrome. It is most common syndrome associated with a focal seizure with impairment of consciousness. And it is a refractory to anticonvulsants, but responsible to surgical intervention. When you ask a question in Viva, or when you ask a short note, what is the type of convulsions, what is the type of seizure, what is the type of epilepsy that responds well to surgical intervention, is this mesial temporal lobe epileptic syndrome. Usually MRI has to be done to know the hippocampal sclerosis and that. But what is important is it responds to surgical intervention. So this is very important. For all the other types of epilepsies, for most types of epilepsies, the anti-epileptic drugs are used, but the surgical intervention is needed for this, because there is ongoing hippocampal sclerosis. Unless you do surgery, you can't prevent the seizures from happening time to time. This is a picture of sclerosis that you can see in MRI. And I'm going to tell what are the normal causes, what are the basic causes of seizures and epilepsy. It is the seizures are a result of shift in normal balance of normal excitation and inhibition in the CNS. 3 clinical observations emphasizes how a variety of factors determine why certain conditions may cause seizures. The normal brain is capable of having a seizure under the appropriate circumstances, and there are differences between the individuals in the susceptibility or threshold for a seizure. There are a variety of conditions that have an extremely high likelihood of resulting in chronic seizure disorder. This is a table where you can see some drugs or the other substances that that provoke seizures. As you can see, important ones, you might not know the entire table, but see the important antibiotics. The antimicrobials there, that is the third one. You must know some things. Beta-lactam antibiotics are commonly used antibiotics in our day-to-day, or even over the counter also they are given. So you must know that the beta-lactam antibiotics and quinolones are very important group of antibiotics, and those should be avoided with having a seizure activity. And anti-tubercular drug that provokes the seizures is isoniazid. As you can see that the table, the third one, antimicrobials and antivirals, and in that subset you can see that beta-lactams, quinolones, acyclovir is something. Isoniazid is very important drug that you must remember that. And the other things you might not offer that useful. As you can see, last but one, alcohol, it provokes seizures. But the important things that we must remember is the second thing, anti-malarial. What are the anti-malarials that provoke seizures? It is chloroquine and mefloquine. Chloroquine is very important. It is a basic drug that is given to the malaria. But if the patient is having a seizure already, and if he is having the malaria, you should not prescribe chloroquine, or you must prescribe it in a dose which is very low, and it better you avoid chloroquine in them. And antimicrobials, which are very important, that provoke seizures, are the beta-lactams and quinolones. And anti-tubercular drug, which is most commonly used, is isoniazid. You must remember these things, and if the question is given, you must also mention them. It's very important. And now, briefly, I'm going to explain how to handle a patient having a seizure. So, in the first table, don't get by seeing the whole table. It's very easy. You just have to write it in an orderly manner, so that you get much more. The marks will be more, and also you know how to handle a seizure. As a doctor, you must know how to handle a seizure. So, how to approach that case of a seizure? It is very important. It looks, it looks like a big table, but it's actually very, very simple. As you, I will explain it now. Just concentrate on what I say, and it's needed for you for the examination purpose, for viva purpose, and also, for the practice afterwards. So, when an adult patient is having a seizure, first take history. What is the kind of a seizure? What are the associated activities and all that? And some physical examination for how to do a neurological examination, right? So the power, you have to check the tone of the, and you have to check the GCS of the patient at that point of time. And what are the differential diagnosis? I will explain it later, but you must know the differential diagnosis is the syncope. As I said, after the termination of a seizure, the patient is mostly unresponsive in generalized seizures or in those type of seizures. So when you see the patient in that form where he's not having consciousness, you're going to misdiagnose it as syncope, which treatment is completely different from that of a seizure. So you can mistake that, and you can just keep the fluid and send the patient away, and again he comes back with the seizure. So you must exclude what is whenever you find a patient of syncope, you must ask the related questions like seizure, whether he's having tonic-clonic activity, whether he's having abnormal behaviors, and you must diagnose, you must differentiate it from a seizure. Transient ischemic attack. You know that in transient ischemic attack, the brief neurological dysfunction occurs, but there is no, you must know the definition of transient ischemic attack. There is no MRI findings or CT findings. There is no imaging findings, but the patient transiently for the period of 24 hours can have a speech disorder, or some vertigo, or some abnormal talking speech patterns, and it can happen even with a seizure. Migraine is one of the leading and acute psychosis. As migraine, also the vertigo occurs. In seizure also, before the seizure attack occurs, there will be vertigo. As I said earlier, there can be the sense of fear. These type of auras, you must differentiate it from that. And the patient is already having so then it is that. And if the patient is already having a seizure and he comes back with the seizure, then you must know that what are the anti-epileptic drugs that he's using, and you must know the levels, whether he stopped the medication or not, whether he's continuing on medication, or whether he's using a low dose, whether he's using a high dose, what are the other drugs that he's using along with the epilepsy. You must take that history when he's already a known epileptic. If he's not a known epileptic, if there is no history of epilepsy, then you must, as I already said, what are the basic causes of seizures? You must do the electrolytes, glucose levels, the urine analysis, and all that. That is a basic thing. And here, when he's using anti-epileptics, then also you know the type of epileptic drugs, and go on with these investigations of electrolyte. The basic electrolytes and urine analysis must be done, and then you must go for the imaging or whatever the anti-epileptic therapy. But this is the basic approach to a patient with seizure. You must mention it when it is given in a when it's given as an essay question. First history, the differential diagnosis, and if it's an epileptic, then you take the history of epileptics and then go for the other investigations. And then if they are normal, then you go for the imaging, or if they are abnormal, treat them like that. If the seizures are associated with any infective etiology like meningitis, then you go for lumbar puncture and all that. But this is the basic thing, and ultimately you treat according to the EEG and all that. Treat accordingly, depending upon the type of seizure, you give that specific anti-epileptic therapy. What are the differential diagnosis of seizures? It's very important. As I said, syncope. Syncope is one of the most important DDs of seizure. You must be able to recognize it. You, as a doctor, you must be able to differentiate it from a syncope and seizure. If you miss that, it will be a problematic to the very problem. It would be the patient keeps coming back with the seizures, and there will be a very high level of morbidity for the patient, especially for the young patients. Some subtypes are very common in the young patients, and you must be able to differentiate it from the syncope. Other things you can usually in psychological disorders, metabolic disturbances, and all that, transient ischemic attack and sleep disorders, as I've already mentioned. But syncope is the most important thing that you must know, and other side things you must remember: metabolic disturbances, alcoholic blackouts, and all that. But syncope is important. There is also migraine, which is a stroke mimicker. Sometimes the migraine can be present with the vertigo. You might get confused with that, but the most important thing is syncope. That whenever in Viva, whenever the question is asked, what is the most important DD of seizure, you must mention it as a syncope, and that is the most basic thing. And if you remember the other things as well, psychological disorders, sometimes a panic attack can mimic a seizure. Sometimes a metabolic disturbance, hypoglycemia, transient ischemic attacks, and sleep disorder. If you also tell them, it would be very nice. But if it is only syncope, if you have to tell one thing, the most common is syncope. As I said earlier, what are the differentiating features between the seizure and a syncope? You might not, you no need to remember or by heart all these things, but minimum things that you must remember is last you can see in the downside of the table the biting of the tongue, incontinence, and headache. As you can see, the last three columns, biting of the tongue is present in seizure and it is not present in syncope, and also urinary incontinence is present in both. And also the postictal confusion is the most important thing. Tongue bite and postictal confusion, it usually separate the seizure from the syncope. Other things you might not, those are not that important to you. But you can also see the sixth column, duration of tonic and clonic movements. It is usually 30 to 60 seconds in seizure, and in syncope it is never more than 15 seconds. The most important thing is postictal confusion in seizure, and the duration of the tonic clonic movements and the tongue bite. There are the psychogenic seizures. Actually, one subset you must remember. They are non-epileptic behaviors that mimic seizures. They are often part of a conversion reaction. You must have an idea of what is a conversion reaction. You will get that in a psychiatry. And certain behaviors such as the side-to-side turning of the head, asymmetric and large amplitude shake movements of the limbs, twitching, and all four extremities without the loss of consciousness, and pelvic thrusting are commonly seen in psychogenic seizure. Whenever you see these things, you must differentiate it from the actual seizures that's going to happen. Actually, EEG differentiates between that, and also measurement of serum prolactin, and also differentiate from epileptic and psychogenic seizures. And the basic treatment of seizure and epilepsy that I'm going to tell you. First, treatment of the underlying condition. If there is any metabolic abnormality, whether it is hypoglycemia, the sugar levels, whenever the patient is having seizure, you must check the sugar levels, calcium levels, and the sodium levels. First, if there are any other conditions, if there are the conditions that are present in a patient of seizure, you must treat them, you must correct them. And the avoidance of precipitating factors, whether sometimes the stress can precipitate it, sometimes the infection can precipitate it, precipitate the seizure, sometimes the brain, any lesions in the brain can precipitate it. So you must avoid the infection, you must avoid whatever the avoidable factors you have to avoid it, you have to avoid them. Suppression of recurrent seizures by prophylactic therapy with anticonvulsants and surgery, and addressing a variety of psychological and social issues. If the sole cause of a seizure is a metabolic disturbance, treatment is aimed at the reversal of metabolic problem and preventing the recurrence. Therapy with anti-epileptic drugs is usually, AED means anti-epileptic drugs. I'm going to use this AED here in the second ring. AED means anti-epileptic drugs. Is usually necessary unless the metabolic disturbance is corrected. Seizures caused by the brain tumors. That means if there is any metabolic disturbance, you keep giving anti-epileptic drug, it's of no use, because unless you correct that particular metabolic disturbance, those anti-epileptic drugs are not going to help you much. Seizures caused by brain tumors, vascular malformation and brain abscess may not reoccur after appropriate treatment of underlying lesion. However, despite the removal of structural lesion, there is a risk of seizure for that due to, in some conditions. I think you must know the main precipitating factor for seizure, sleep disturbance, as I said, in myoclonic epilepsy. So the patient is advised to have a good quality of sleep. There may be association with alcohol intake and seizures, stress and seizures. So the sleep must be adequate for the patient. Minimum of 7 hours is needed for the epileptic patients, and also the timing of the sleep. You can't be awake for the late nights and all that. So if there are the job related things, if the patient is having any job related, when he is associated with any night duties, when he's doing any stressful work on the nights, usually it must be, the patient must take the break from them, or even leave that kind of jobs, because the sleep deprivation, particularly during nights, is very cumbersome. There may be association with alcohol intake. There are also relatively rare causes of patient that are induced by high specific stimuli such as video games and music, and sometimes suddenly the music which is of high volume can precipitate seizures. Sometimes even you're watching the screens with the heavy lightings and all that from the near. Most patients get seizures even in a cinema theaters, because they watch the monitor from close on. So those type of things can actually precipitate them. So these are relatively rare usually. And the basic drugs that are used in the generalized tonic-clonic seizures, whatever that are mentioned in the first line column, that is, you must remember them. You must remember the names of the drugs, of the anti-epileptic drugs, and the doses to some extent up to what are the time for which they are used. I will mention, but first remember the names. What are the first line names that are used for first line drugs that are used for generalized tonic-clonic seizures? It is lamotrigine and valproic acid. Usually in our setup we give the sodium valproate, that is valproic acid, which is very important. And for focal seizures, you can see that lamotrigine, carbamazepine, phenytoin, and levetiracetam. So as you can see that the phenytoin, usually many people think that phenytoin can be given for every type of seizure. No, it is one of the first line drug given for focal seizures, phenytoin. Levetiracetam is a very important drug that is used mostly in these. Nowadays it is used because of the lesser side effect profile, levetiracetam. So lamotrigine, carbamazepine, phenytoin, it's very important for the treatment of focal seizures. In typical absence seizures, the first line drug is valproic acid and ethosuximide. So you must remember that the valproic acid is a drug of choice for absence seizures. Most of the people have thinks that is ethosuximide, but no, it is a first line drug is valproic acid, and then ethosuximide can be given to the patients who are lesser in age. And for atypical absence seizure, valproic and lamotrigine. But you must remember the names of these drugs, that lamotrigine, valproic acid for generalized tonic, and the second line you can use them, but you must mention the first line drugs that are used for the treatment of This is the extension of the generalized tonic-clonic seizure. As you use, the initial choice can be first valproate, and it is given in this table is about the availability of the drugs. Usually, the availability valproate and carbamazepine are available normally, even in the counters. So depending upon that, but you depend. I mean, usually go with the first, the previous slide, this one, and then it is given on the availability of the drugs and also in the childhood seizure disorders. I mean, these are in the trials. These drugs are in trials, which are not of that important to you. And when to initiate the antiepileptic therapy. Antiepileptic drugs should be initiated in any patient with recurrent seizures of unknown etiology or known cause that cannot be reversed. I mean, known cause that cannot be reversed means, for example, in a patient of neurocystic cirrhosis or in the case of tuberculoma, there is a lesion in the brain that keeps provoking, the neuronal networks and increases the discharges. So we can't reverse that. We can't reverse the lesion, or so we can't, completely cure those lesions. Those lesions get calcified and get stuck in the brain. So for those type of patients, you might you have to give the antiepileptic therapy for so long, almost lifelong, and they must not stop those things. And sometimes we don't really know the etiology. So in those patients, we have to continue antiepileptic therapy. Whether to initiate antiepileptic drugs in a patient with single dose of seizure is controversial. Usually, when a patient is having single episode of seizure, we are giving antiepileptic drug therapy now for a period of 6 months to 8 months, and then we gradually stop it and see. Usually nowadays, in OPs and all that, we usually prescribe antiepileptic drugs for even a single episode of seizure, but not for lifelong. We're going to give it for 6 to 8 months, and then we'll see. The patient with single seizures due to a CNS tumor, infection, trauma in which there is a strong reason that the lesion is epileptogenic should be treated. Risk factors associated with the recurrent seizures include an abnormal neurologic examination, seizure presenting with the status epilepticus, as I'm going to tell you what is status epilepticus in the coming slides, post-ictal thoughts paralysis, as I mentioned earlier, and a strong family history of seizure and abnormal EEG. These are the strong risk factors, and if any patient is having these things, they must mostly use the antiepileptic drugs for lifelong. And how do you monitor when we give an antiepileptic drug therapy? The goal is to prevent seizures and to minimize the side effects of antiepileptic drugs. Monitoring of the antiepileptic drug levels is needed to prevent the side effects, because these drugs have to be used for so long. It's not like an infection for fever like that, 1 to 2 weeks or like that. They have to use them for months to years together. Sometimes they have to use the lifelong. So you must check the levels of, as you check the paracetamol levels, as you check the other drug levels in the blood. You have to check when the patient is using phenytoin. You have to check the phenytoin levels in the blood, and to prevent the side effect, you have to know the side effect profile of that particular drug. The concentration of free drug levels, which reflect the extracellular levels in the brain, and correlates best with efficacy. Thus, patients with decreased levels of serum proteins may have an increased ratio of free to bound drug, and those drug monitoring is required. If the seizure continued despite gradually increase to the maximum tolerated, then it is necessary to switch to another antiepileptic drug. The dose of second drug should be adjusted to decrease the seizure without causing the toxicity. And whenever it is possible, you have to use a single drug. If the patient seizures are controlled with a single drug, then monotherapy is most useful to prevent the side effects and also prevent taking many medications for the patient. The genetic thing is not that of useful, but you can remember HLA-B1052 are associated with carbamazepine, but it's not needed for you. When to discontinue therapy? When there is when you give the medication and the seizures are controlled within 1 to 5 years, then you can discontinue and have to monitor the patient and have to keep the patient in a regular checkup. Regular periodic checkups within a gap of 2 months or 3 months. And a single seizure type with generalized seizures has good prognosis than focal seizures. And the patient is having normal neurological examination, and EEG becomes normal, then you can discontinue the therapy. But while discontinuing, you have to keep monitoring the patient, because most of the time the patient stops the drugs and comes back to the hospital with another seizure attack. The treatment of refractory epilepsy, the patients who have focal epilepsy related to an underlying structural lesion, or those with multiple seizure types and developmental delay, are likely to require multiple drugs. The initial combination therapy commences first-line drugs, and the patients with myoclonic seizures resistant to valproic acid may benefit from the addition of clobazam. And surgical treatment is not that important to you. And most important thing, it is separately can be a very important question that may be given. It can be given as important long notes or short notes or whatever. This topic, status epilepticus, is going to be asked everywhere, actually, in theory, in viva, or whether you further go to internship, wherever you go, this status epilepticus, as a doctor, you must know this. You must know this condition. You must know how to treat this condition, and you must know how to evaluate the status epilepticus. Status epilepticus refers to the continuous seizures or repetitive discrete seizures with impaired consciousness in the interictal period. For example, if the patient had a seizure for 1 minute and there is no seizure for 5 minutes, and there is a seizure after 5 minutes, and if there is no consciousness between these two periods, these two episodes, then you call it as a status epilepticus. The most important term there is impaired consciousness. There should be impaired consciousness in status epilepticus. The patients with continuous seizures or repetitive discrete with impaired consciousness in interictal period. This is most important thing. Impaired consciousness in interictal period. Duration 15 to 13 minutes. And usually this the most common thing that's going to is generalized chronic seizures. As it is, it's an emergency, and it is an emergency actually, status epilepticus, and must be treated immediately, because if you get seizure continuously, there's going to be a respiratory dysfunction. As I said, there is a loss of oxygen to the brain, it causes ischemic injury to the brain, and also there is a cardiorespiratory dysfunction, hypothermia, and metabolic derangements can develop, which may lead to irreversible neuronal injury. The most common causes include antiepileptic drug withdrawal. It is most important cause of status epilepticus, where there is antiepileptic drug withdrawal or non-compliance, metabolic disturbance, drug toxicity, and CNS infections and tumors. Most common thing is anti-epileptic drug withdrawal, or non-compliance means the patient is not taking regularly. For example, he has to take a drug OD dose. That means once daily dose, but he's using just once a week, or he's taking whenever he feels, whenever there is it is comfortable. This is called non-compliance. He is not taking the drug properly or in a required dose. Metabolic disturbances are the second most common thing. As I said earlier, hypoglycemia, hyponatremia, and hypocalcemia, and drug toxicity. Whenever you're using the drugs are above the level of the normal serological level. CNS infections, meningitis and encephalitis can end up with the status epilepticus, and tumors of the brain. Persistent absence seizures or focal seizures with confusion or impaired or partial impaired consciousness. And this is how you treat a patient of status epilepticus. Whenever you suspect the patient of status epilepticus, first check the sugar levels. That is very important thing. You have to check the sugar levels. If the sugar levels are normal, then immediately you have to give LZP, means I think the short forms, the elaborated forms are given below. You can see that. First, IV benzodiazepine. You must write the thing there. IV benzodiazepine is a first-line drug that to be given in status epilepticus. You have to give lorazepam 0.1 mg. It is very important that you have to know by this. You have to know the drug with dose. It is very important. Lorazepam 0.1 mg per kg or midazolam 0.2 mg per kg. Lorazepam or midazolam has to be given initially, or if they are not available, then clonazepam should be given. But lorazepam or midazolam is those are the drugs that you must know. First, they have to give IV benzodiazepines, means lorazepam or midazolam. And if the seizure attack doesn't terminate also by giving the lorazepam or midazolam, then you have to go with the other drugs like phenytoin. PHT means phenytoin there, 20 mg per kg, or valproate, 20 mg per kg. All these drugs are IV drugs because the patient is having impaired consciousness as it is an emergency. You have to give the phenytoin or whatever you give, you have to give IV there. There is no, oral medications here that you must know because it is an emergency. You have to rescue the patient from a seizure attack, and you must rescue the patient from the cardiorespiratory dysfunction and all that. So you have to give the IV medications here. First lorazepam or midazolam. If the seizure attack doesn't terminate, then you have to give phenytoin 20 mg per kg or valproate 20 to 30 mg per kg. Then if the seizure attack keeps going on, and if it is a generalized seizure, that means that there is vigorous movements of the hand and feet, then you have to keep the drip, that is a midazolam drip, you have to keep it, or you can even go for a propofol, and PRO means propofol there. IV midazolam or propofol drip must be given. Even if that is not available, or if still the seizure that doesn't get subsided, then PTB means phenobarbital. You have to give the phenobarbital. I think this is the common thing that you must give. And if the phenobarbital is not available, then you can go fluoxetine, desflurane, ketamine, and all that. But you have to remember the lorazepam, phenytoin, and midazolam and phenobarbital. You must remember these 4 drug names, and you have to mention them along with the doses. You have to mention them that they have to give IV. It is very important question, and you must. Okay, 2 minutes. Okay, I think it's better to know up to this point that the treatment of status epilepticus is very important, and this table is very important. And in a whole today's class, you have to remember the treatment of status epilepticus, which is very important, and when to continue, when to start the anti-epileptic drug therapy, and the basic drugs that we have to use for the seizures. That is a very important thing, and I'll stop at this point of time. There's not much left there to tell you, but what is most important thing is this chart, this the treatment of status epilepticus. What is how do you term status epilepticus? Impaired consciousness between the intellectual period, and then you have to know what are the drugs that must be given, what are the first line drugs for each subset of seizures. There is generalized tonic-clonic seizures, absence seizures, and thank you. There are not much to tell in the other thing. Ketamine and epilepsy drugs are not needed for you. Usually in pregnancy, you can continue the same drug, as a monotherapy. So there is not much there to tell you. So if there is a possibility, I'll take you in another class, the contraception and all that, pregnancy and post, how to use anti-epileptic drug therapy during breastfeeding. But it's not that important to you. What is important is this thing. What is the treatment of status epilepticus? Everyone must be able to tell this. IV benzodiazepine, phenytoin, midazolam, propofol, and the phenobarbital. All of them are given IV, no oral medication. So whatever carbamazepine is an oral medication, it is not given here. You must remember that. Okay. Thank you. Hope go and have a glance at these topics. Once again, so that you can have a better understanding. Status epilepticus, you must know, it is asked everywhere, literally everywhere, as a theory, as a viva. As you go on to further move on to the internship, you will be facing that at every point of time. You must know that. Thank you.